Hey, can you guys hear me okay?
Yep.
Okay, got it. All right, thanks. I think this automatically is recorded, just so you know, as we start this. I can stop the recording at any temporary time for any purposes if people want to go off the record, so to speak, right? So at this point in time, I'm going to see who's on, and I got to do that usual thing where I'm moving everybody over. The Florida one just, as usual, went over. So, attendees. Okay, here we go. Looks like we got mostly a panelists on. Hey, Doug, Eric, here we go. Hey, Doug, you get my email last night? Did that you agree with that? Were you okay with that plan? Promote the panelists. Doug Kupis.
Yep, I'm on, Paul.
Yeah. Hey, did you see my email? Did you agree with that plan? Are
Oh,
you
yeah, I
okay?
did. I responded to that.
Okay, good. I just haven't seen emails this morning. I've just been busy from minute one. Just trying to move everybody over. So thank you very much for your patience, everyone. Hey, Glenn, did you see that thing we sent out on behalf of the LA Commission out there?
Yes, I did see that. Unfortunately, I'm not going to be able to make the next two meetings. I have flights, so I won't be able
Yeah.
to participate next week.
So what we'll do is I still want to get you plugged in with him ahead of time, just maybe have an off the record. I mean, off the
Sure.
just between you guys. And all I'm saying, not off the record, but just
Yep.
one on one, because you guys have state laws there, I think, that say for a certain percentage of paramedics that you have to have a medical director, which I thought was very thoughtful. Okay, so uh, okay, got it. And Gail, I'm trying to get you pushed over. I don't know if you're seeing that or not, or just can't do it. Oh, we'll be rejoining. Good. Okay, good, 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 good. All right, I think I captured most of the people. We got a pretty good quorum showing up already. I'm waiting for a couple of people to come on, including Tony Cirillo, I think. I didn't see him here yet, so I'm promoting away freely on this other side. And we're going to sort of start off with that. Here we go. Rob Lou. Okay. Sean. Hey, Sean, it's really good to see you. I hope you can come to Hawaii this year. I mean, from Hawaii to Fort Lauderdale, right? Because you've never seen a beach, right, out there in the wilds of Hawaii. I hope you can come on over. I want to try to move you over. Here you go. So I haven't seen you for a while, Sean. You doing okay?
Sorry, Paul, I had to rejoin as a panelist.
Yeah. No, that's okay. Hey, so I'm just hoping that you can make it to Florida this year. That's also, and want to see how things are going. I haven't talked to you for a while. It's really good. So, all right. So, any event, are things going okay there? What's the latest happening in Honolulu? See what the chat shows here. I got to get rid of the chat. Okay, every favorite CME code is good job. Thank you so much, Jim. Thank you for being on. I appreciate it. Well, I'm waiting for some attendees to get on here and then we can get going. Um, I don't know, Jim and one of the people I'm expecting is Tony Cirillo to come on and give that talk, Sandy, that you asked me to have him do,
Yep.
right?
Yep.
And but maybe even before we get started, so we can move along. He's the new he was the president-elect last year, and now the president of ASAP. And I thought maybe you and Jim know him the best, right? And so, any event, let me know if there's any issue of
Yeah. I
you
just
know.
pinged him.
Yeah, yeah, okay, good. But anyways, in the meantime, Jim, you've known him probably the longest, right? And hang on for a second. I'm getting a thing from Peter, like they want to know why I left the other meeting. Well, because we have this meeting. Here we go. I gotta find out what I do with the phone now. Here we go. Um, so in event, let's see if I get rid of that. All right. So, anyways, let's start off with Jim. You've known him the longest. As an intro, why don't you go ahead and get going? Okay.
Tony Cirillo is a wonderful emergency physician. His background is in Rhode Island. He's been involved in their state systems of care, emergency care, for many years. That little compact state has extensive interaction between emergency departments and EMS. So EMS, not a formal part of his background, but he's very knowledgeable. he's also one of the lead people in legislative and advocacy. And as part of the physician group that we were both in, he was our advocate. And he worked at the national level, at the state level, to make sure emergency physicians could represent their needs and the needs of their patients very well. So that's what Tony is most famous for. He thinks very much like someone who knows the state systems and knows the federal systems really well. And he's been representing us for many, many years. We're blessed to have him, and I hope he has a good message for us today. Thanks, Paul.
It says I just got a note from Nick Kazi, which is interesting, and he said Cirillo said he would be able to join at 12. Okay, which is the time slot I had set for somebody else, but we'll get it all together. So in the meantime, we can maybe do our quick round robins. We can do a quick round robin. So let's see. Here's Nick's coming on here. Let me go ahead and get him over, and he can maybe tell us what's going on. So that'd be good. And then Sandy, I'll have you make some comments as well at that point in time, etc. And set things up. Doug, how are you doing on time? Will you still be able to hang around then afternoon or after what? I guess afternoon your time, right?
I'm doing great. I plan to stay with you to the end at 1:00.
All right, good. Okay, good. All right, thank you then. Because I want to be respectful of your time because I want you to be a kind of a closer on this issue for the EMS or sort of side of things. And you guys put out a very nice. If you can, why don't you put that into the chat? Can you put the nice summary of the discussion we're going to have about the DEA into the chat? That would be great. Okay, so everybody has that nice summary. Okay. So here's Tony. He's getting on now. So maybe we can get going. So never mind, right?
So he didn't answer my telephone, but he answered or whatever.
Okay,
Okay.
Tony, I hope
Emily Latella would be very proud of you.
Yeah. Right, exactly. Not many people know what that is, Jim, at our ages, right? That kind of thing. So, anyways, never mind, right? What was this? Remember, there was one of the ones was, what's all this talk about Russian jewelry? And they said, no, it's jewelry. Yeah, right. And he goes, oh, never mind, right? That was a great little shtick they did on Saturday Night Live. All right, Tony, are you on with us?
I am, Paul. How are you?
Okay, good. Thanks a lot. So, Jim gave kind of a little bit of background on you in the background, okay? And Sandy, can you give him more of an immediate
Oh, no.
recent
She
background?
doesn't get to say anything about me unless I get 2 minutes for rebuttal.
Okay, well, I'll give you that's what's nice about this whole meeting is that there's always 2 minutes for rebuttal, right? That kind of thing. And the emphasis on the but part, right? So that kind of thing, right? So any event, Sandy, go ahead and do a little introduction, as our chief medical officer. And you were the interim executive director of ACEP during his let's say rise to fame.
So he's one of the nicest, kindest, thoughtful, always willing to admit that the other person is right. Oh, wait a minute. Did you want me to do Tony?
Yeah.
Oh, I thought you wanted to do Jim.
Yeah.
No,
Okay. Yeah.
Tony has been on the board now for several years and doing an absolutely marvelous job. I was delighted when he was elected last year to be president-elect, and delighted to be able to step down as interim executive director when he became president, so that he became somebody else's problem. I'm sorry, so that he has a great vision for emergency medicine. I'm glad he's going to be here to talk a little bit about the DC office and what we've done, because that's really one of his major strengths.
Yeah, in the advocacy realm, it's always been there. It's just been terrific. So, anyway, it's just really glad that he is just everything you just said, just a terrific person. But the thing is, you know why? It's because he's married to this amazing woman, right? So, Tony, if you don't mind, tell us a little bit about Libby and what she does, if you don't mind, unless you think it's inappropriate. So.
Well, thanks everybody, and I appreciate the opportunity to join this august body. I told Paul, and as I look
Well, we're
around the
not
room,
August. We're more like July.
yeah,
So go ahead.
uh, particularly my long friend Jim Augustine, who has been a mentor of mine, and I got to be with Doug and the rest of many of you out at NEMSP in Tampa. So. I told Paul, and Sandy knows this, I'm like one of many emergency physicians who in their career gets asked to do EMS, but it's usually at an ask from the hospital, to kind of be the local medical director. And that's evolved over time. And I've watched that over my 35-year career now. And the amount of professionalism that now really defines EMS at all levels, administrative, field, medical direction. Truly it is, we've kind of watched this grown up. So again, appreciate the invite. The reference to my wife is she's a middle school teacher, but she teaches robotics and technology. And now, if any of you ever repeat this to her, I will deny it, and I'll say Sandy did it. But my wife actually wanted to be a social studies teacher, but teachers tend to last for a while. And in our little town where she wanted to teach, there are only 4 middle school social studies teachers, and they have been there for a couple of forevers. And so she finally just did substitute teaching, and then they said to her one September 1st or whatever it was, there's no robotics technology teacher, and you don't need a certification specialty to do that. And she said, well, I'll do it. But I will just point out that she looks at her phone and goes, those little boxes on the phone.
Yeah.
You mean apps? Yeah, the boxes. And that's where she started her proficiency in technology. But I think the moral of that story is she knew what she didn't know. Much like the rest of us, you have to admit what you don't know in order to be smarter and better tomorrow. And then the other thing is she really tapped into that with the kids to let them teach her. And so it became a back and forth of they're teaching her as she's teaching them. So, I think that's a good life lesson for all of us to learn.
I was fascinated by the fact that you said, first of all, they're teaching robotics in a middle school,
Yeah,
let
middle
alone,
school.
let
Yeah,
alone high school, that kind of thing,
yeah,
and all that. But part of it is also there's more to it, isn't it? In terms of certain skills and thinking processes that she's helping to guide them with, and develop them. So I thought that's just a fascinating thing about
yeah,
Libby. So
yeah,
okay.
yeah, yeah.
All right. Well, listen, let's go ahead and get on with the program. And the way I'm going to do this is have Tony go ahead and tell us what the issue was, because this took 9 years, almost a decade to get this done. And but we come to it and just sort of give us what was this, and then why did it take so long, and what finally got us through, in your opinion? And
Yeah.
then Jim, I may have you comment on it because you've always, you and Craig Manifold were always following this for us. And then finally, as far as like summary statements for the EMS people, I'd like Doug Kupas to be our closer and give us a glow if we can do it in that manner, if everybody was okay. All right. So thanks. And by
Yeah,
the way,
so
as a note, in the interim, Doug did post in our chat the summary statement that was put out by it's like 27 pages, I think, or something like that,
yeah.
about the regulations. But he put a summary in there, I believe, for us in the chat. So, all right, Tony, go ahead, hit it. Thank you, and welcome, Monsieur President. Okay.
Thank you, Paul. So again, you all know this topically more certainly than I do, but the issue of how to ensure that EMS providers who are going to be the first people to provide care, have access to the right medications and the right therapies. And you can see, Doug, thanks for putting that up in the chat. This was the act of 2017, and you're like, wait a minute, we're 9 years later. Well, what was going on? And first of all, I think it's, again, kudos to all of you who pushed the issue of, EMS is not, what it used to be. And with advanced training, with advanced skills in the field, the recognition that the oversight of medications, including, narcotics and, other controlled substances, have had to evolve. Right? The hospitals were evolving, control of those substances, and how to define a system that made sense for EMS as a standalone component of the healthcare system. Certainly, the bill made sense. It was this issue of trying to get regulations. And I'll just say the moral of the story is, look, if you know the right thing needs to be done, you don't ever stop. Right? That this was not anything that ever fell off of the radar screen, certainly not for ACEP. But the other part of advocacy is there, you always have to be ready to jump when the window gets open for you. And, in each administration, they have certain priorities and, things come up, COVID gets in the way of a lot of stuff. And so you just have to be persistent and you have to know that you always have to keep reminding them that there's something you still haven't finished on this. And then all of a sudden you find somebody in the administration who the light bulb goes on and they go, well, we can do this. And then they're motivated and then they want to take ownership of it. And then all of a sudden you get regulation. So, I think again, as the specialty of EMS evolves within emergency medicine, I'm happy that somebody in the administration, and I'm going to give kudos to our DC staff who clearly were continuing to work this behind the scenes. If you get somebody to kind of that light bulb goes on, hopefully now we can continue to work through that same channel as we talk about other things, and I know it's whole blood in the field and maybe we can get them to think about now that they've given us access to the medications to actually help us not have shortages of these medications that you can all now manage because that's becoming again, it seems like that's flared up again that there are shortages of controlled substances not just at the EMS level, at the hospital level. And then I will say the one thing that I think if we can all, I think the next thing that I would want to see us all collectively work on is the issue of the tracking of resources, including beds availability. Where's the right place for that person to go? How do we get them the right resources to get them there in a coordinated way? Because, I still hear from docs who are, making phone calls to, 5, 10 facilities to try and get someone transferred. I mean, that is just a colossal waste of the physician's time and is doing the patient no good. So I know there are efforts and collaborations around that issue of dashboards and tracking boards. I would love to see us, collectively as a house, push further on that because I think that fixes a lot of problems for everybody on a day-to-day basis. And then obviously that translates into if you use that system on a day-to-day basis, expanding it when you have a mass casualty or a disaster and people are familiar with the system, we know that is a recipe for success as opposed to trying to get people at a hospital to use a tracking system that they haven't opened the application in 6 months. So that's my less than 5 minute spiel because I know Paul Pepe has a reputation for telling people you're done. So I'm done.
Okay. Oh, I thought you were Cirillo. Whatever. So good. Hey, so Tony gave you sort of overview of the issue and we've learned this from people like Charlie Sand that you've just got to be persistent and keep doing it, and then finally you make it work. And Jim, you've been tracking this a long time, but can you tell us what the issue was that we had to get around and get solved and get fixed that finally got fixed? Would you mind doing that?
One of many. Tony Cirillo, good to see you. It's good to see Julian Maldonado on because this is an issue from Craig Manifold. There were, Craig had a big presence with the DEA. Much of this deals with the EA regulations and how they wanted to frankly take controlled substances away from emergency medical services and medical directors. And Craig, until he died, was very active in this issue and was our representative. So the point is medication should be available and they should be available through protocols and medical directives that come from us and quality assurance that come from EMS medical directors who are doing a great job. And that's as simple as it gets. It's that point that Tony said about continuing to advocate for our practice and the people that we represent and our persistence looking kind of at our grocery list and knowing what the right time is to ask for certain of the groceries. Thanks, Paul.
So Jim, one of the things that we've dealt with over the years, especially with Craig, and for those who I hope everybody knows Craig Manifold, because he was the one that started these Zooms in the first place whenever we had a crisis, whether it was Ebola, then later on to COVID, et cetera. And Julian worked with him and facilitated, and she's still on with us. And, we called this weekly meeting the Craig Manifold Lectureship, not memorial. He's here with us all the time. He was a terrific muse for me, just as you are, Jim. And but one of the things we would have is that we would have to have every fire station would have to be a DEA you know, and you had to make out a different form, et cetera, for that. And then, as you were saying, the issue here was they wouldn't let us use controlled substance as part of a protocol, right? That was what the instruction is. Am I right, or correct me on those two subjects?
That's one of the pieces of it. Yes.
Yep. Okay.
They wanted all kind of restrictions, and still today, if you talk to DEA, they insist that all of the narcotics that go in our system are diverted, because that's the cases they deal with, and that every patient who supposedly is getting their narcotic is instead getting saline that's been placed in that syringe.
Having said that, what we find is that it actually is more of a regional challenge, if I recall well,
It is.
is that there are some areas where the DEA people are getting it, but if you get stuck with some kind of person who's reading some lines that are very linear thinkers, it could go to hell in a handbasket there and have people get into trouble. Because they were even reporting that there was a problem in our system, you know, as they thought they should as a medical director. We've seen that happen here in Texas, right? Some years
Yes.
ago.
So the Texas office was one of the ones that had become very restrictive, even when the Detroit office, the Miami office, and others were less restrictive in dealing with EMS. The Texas office was particularly difficult to work with, and that's where Craig kind of got his teeth.
Speaking of people who help get legislation through, Stan, I just saw Charlie got on. I wish he had heard the earlier part of this. I'm going to go ahead and promote him over. Doug, what does this mean for all of us? Go ahead and our president of NAMSP is here, and Doug, go ahead and tell us what the implications are of what passed and what it means for us now.
Sure, absolutely. And if it's okay, I'm just going to, some may not have brought it up yet. Let me just share screen with you here also, just
Sure.
so you can
Let me.
see
Good. You're sharing.
what was
Good.
posted. So, people are correct. This was an ongoing issue. Now, we have to understand that this act is all just about the DEA and controlled substances. So, we have a lot of other medication issues, and I'll put in a plug for our House Resolution 3443 that we're trying to gain momentum on. Done
Right.
by the same, which looks at shortages of many essential medicines for EMS. This is just about controlled substances, and we were seeing exactly what's been explained, that the DEA regulations never even thought about EMS. They were done back in the 70s, and there was nothing that ever said EMS medical director, the idea of protocols, etc. So offices were around the country were very variable in the way they were looking at this, and suggesting that like every ambulance had to have its own DEA registration, etc. We also, I think, at NAMSP, we saw a lot of medical directors putting themselves at personal risk because there were people using their own personal DEA number in conjunction with what they were doing with their EMS agency, which, if you have a diversion at the EMS agency, suddenly you can't practice in the emergency department because it was all under your DEA number. So I think this addresses a lot of those issues. The same Representative Richard Hudson from North Carolina is the one that helped us put this act from 2017 through. And is also the one that is working on our current House resolution. But to summarize this,
let me interrupt you for a second, then, Doug. So at this point in time, does this mean we still have to have a DEA registration at every ambulance, or is that can it be now?
No. So this really takes care of the bulk of these things. And one of the things that we've noticed when we're on the Hill every year since 2017, we're like, where are the regulations for this? Where are the regulations for this? We met on the Hill last year with the Senate Judiciary Committee and said, these regulations are really important. Where are they? The whole committee, or the couple members that met with us, they said, oh, we agree. This is high importance. We need to get this out. And then one guy sitting back at the end of the table said, yeah, but how about that new thing that just went through where we're to have no new regulations and we're supposed to get rid of 10 for every new one we put out? I immediately offered to list 10 that they could get rid of, but they didn't pick me up on that. And so this was still at a standstill. And a little testament, just a little story to the
You look good in that film, buddy.
to the
Got you.
10
Hang on a
organizations.
second. Hey,
Oh,
Don Jenkins, you're live.
I looked a little old.
Hey, Don Jenkins, you're live. Don, you're live. Okay,
He's
thanks.
very
Go.
live.
Yeah, he is. Thank
There we are.
God.
He's muted.
Go ahead.
So the last fall, we had 10 organizations that did a booth at the National Conference of State Legislators on EMS. And it was great because it included ACEP, and the National Association of EMTs, and we had 10 organizations come together and do a single booth. And when we were on that vendor floor, the DEA had a booth. And we went over to the DEA booth and we said, hey, we're still looking for these. And that's when they said, oh, well, we have just changed the rules and now EMS agencies can get their own registration as an EMS agency. And that was a few months ago. They were actually, that same person did a webinar for us and came to NAMSP last week and was a vendor there and had really good conversations. And then right after we came home, this came out. So what it does, it gives key definitions, including things like, the EMS medical director, et cetera. It also broadens what a station house, of all definitions, but what a
Right.
station house means. And in the context of, you do not have to have every station house or every ambulance registered. The EMS agency can be registered. And this defines that they can then store these medications at station houses and in ambulances and that sort of thing through one single agency registration.
Perfect.
So then in item B here, it talks about the agency registration model. And now for the first time, EMS agencies can go in and get a DEA registration. Now, the downside is you have to pay, just like physicians have to pay for the registration. But the registration now is in the EMS agency name, not directly in the medical director's name, which is a really good thing for the liability from the medical director's standpoint. It designates the locations, station houses, et cetera, but it also talks about ambulances. And then the next section talks about the security and storage, including in jump bags or portable bags that medications might be carried in. And it defines when those vehicles, everybody always wondered what like the double locking of controlled substances meant and that sort of thing. In here, it defines when that vehicle has to be locked, when there's a controlled substances in it, and when it doesn't necessarily have to be, completely locked up and sealed also. And some things related to storage, jump bags, et cetera. The next section is about standing and verbal orders. This was also, as was brought up, a real issue with that because the previous regulations said that controlled substances could only be given when they are prescribed directly to the individual who is getting it. Well, that didn't work very well when somebody's having a seizure and we have a standing order for an anticonvulsant that's controlled, but it wasn't prescribed directly for that patient. So this section is really good for EMS. It talks about standing orders, verbal orders, that sort of thing, and outlines those and the process. And it does it in such a way that you don't, you can work through those. It also very specifically says so that agencies that are in states where they have statewide protocols, it references the statewide protocols as the standard that they may follow, and agencies that are, more home rule, it recognizes the protocols that are made by the medical director. Then, there's information in here about restocking, how stocking at hospitals for some agencies that do get their medications replaced at hospitals, and it also has information about the interfacility transport of patients where, somebody might be on a controlled substance and need that going forward. And then lastly, there's a section on the record keeping that is required. Now, I have to say I haven't fully digested everything beyond this summary, which our Holland and Knight folks that are NAMSP's lobbyist group that has worked diligently on this, for many years. They put this summary together for us. If you need more than the summary, then there is the 27-page, if you like reading fine print government regulations and rules. This is the full thing, which I would encourage everybody to actually read because, obviously a summary is a summary, and what they're going to hold people to is what's in these regulations. But that's sort of the overall to this.
Yeah.
And again,
Well,
I'll just put in
let
a
me
final
interrupt.
plug.
Yeah.
Yep.
Yeah, just wanted to interrupt for a second. So first of all, as the quote Sandy Schneider, this is a victory. It really is. I mean, it's
Yeah.
unbelievable.
And many partners have worked hard to help us get this across the line.
Yeah, and my point though is that it really clarifies a lot of things. Finally, they've just been nagging us, and a lot of people have already adapted, and they were doing okay in some of their own regions. But this is just great that this is now solidified, and will take some time. Now, is this in effect now, or is it going into effect?
So it goes in effect. So it was officially published yesterday, I believe, although it was released a little bit the day before that. It goes into effect 30 days after its publication. But it has already been in effect since last September that an EMS agency can go on and apply for the agency DEA registration. Now, there is a caveat here, and it's a big caveat. The states still have tremendous control at the state level over pharmacy things. And whether or not you can use this new designation within your state depends on your state pharmacy rules. And right now, I think it was 23, it's about half of the states recognize this right now, but that means about half of the states do not. So if people try to apply for this from a state where the state pharmacy rules do not allow it, you've got to work through state chapters to work with your pharmacy folks in that state to get them to now recognize this. So there is this little caveat about that. But boy, 2019 until now to get regulations out, really, there were a lot of frustrations. There are a lot of people.
2017,
2017.
Right.
Yeah, a lot of frustrations, a lot of people that couldn't understand this. Harry was I would say that there were some lively debates with previous DEA folks that came to conferences, with Harry being right in the middle of that in the past. But it is a victory. And then my final plug is just, this takes care of one of our things. The title's almost a little deceiving because when you read the title, you think it's related to sort of all medications.
Yeah.
And we really are trying to work to shore up some things with the commonly short medications in the House Bill 3443.
Right.
So we really hope that everybody can work to get.
Yeah. So what I wanted to do here is I want to sort of get on to other topics, obviously, because we've been on this for quite a long time, but it's a big deal. So I thought I'd give it. And also make sure people met Tony, etc. And because I think he's going to be a good ally and a good partner with us, fits in with us very well.
I did get to see Tony in his pirate garb at Gasparilla last week.
Is that right?
Pleasure. Absolute pleasure to have Tony at the NEMSP President's Reception and at the conference and the awards dinner. But he went full tilt on his pirate garb.
I understand. I remember he said something like, "Arg, we're going to kill every last one of them." Arg. So, well, listen, Doug, I want you to give up. I want you on another session. Come back to us and talk about the pending things we want to get out to our representatives, congresspersons, etc. What that bill is, and give us a 30-second thing, and then have you come back and tell us the main parts about what we're trying to get across. But then come back and do a more lengthy thing. We just want to do this as like a tease of what you're going to talk about coming up. You're on mute right now.
Oh, that sounds good. Yeah, I thought that tease was just more later.
Yeah, but go ahead and tell us about the pending legislation, like we're talking about EMS,
Oh,
medical director
okay.
salaries, things like that. That's what, just tell us what it is in 30 seconds, and then we'll have you come back and talk about it.
Yeah,
That's what I'm
the
getting
30 seconds, and some of you have heard about this already. This bill was introduced last spring. We are still getting co-sponsors right now. And we added a co-sponsor from the Florida PAC meeting that we had down in Florida. So the 3443 has three legs to it. For this group, one of the most important legs is that it calls for a MedPAC study of what EMS physicians are, the value they bring, and importantly, how there should be compensation. MedPAC is the organization that advises Medicare on different
Yeah.
groups. Number two is we identified 9 critical medications for EMS that we feel should never go on shortage and should always be available at the same concentration also. And there is a CMMI project that suggests that Medicare should pay more for those because that would incent the market to actually produce them and not let them go on
Yeah.
a shortage.
So,
And
so let's have,
blood is also in there.
so let's have you drill down on it. The reason why it'll be timely if you could come back next week is that it would be a good follow-up to the session we're going to run next week, which is related to something that the LA County Commission has brought up about why do you just need one medical director? Why would you need multiple medical directors in a system, right? That,
Yeah,
we're talking about our large cities here. So
sure.
that's why Glenn is saying, Glenn, you have a law there that requires what for every number of paramedics you have to have a medical director. Is that correct?
That is correct. Per the state Bureau of EMS, we're required to have for any EMS agency within the state one physician for every
Yes.
100 paramedics.
So as it turns out, next week we'll have people like Miramontes, David Purse, who have multiple doctors, that kind of thing ready, and tell us why and why their outcomes are good. Dr. Kevin, look at Ken Shepke, must have 8 or 9, I think, in his system, and it runs so well. So we want to be supportive of the LA people to make sure, and this is really goes along with that, Doug. So if we can have that as sort of a backup to that
Yeah,
as
that's
well.
perfect. We can do more on that. The third leg of the stool is related to wall time
Yeah, yeah.
and trying to get them to basically enforce more strongly EMTALA that's already there related to wall time when a patient presents
Yeah.
themselves to the ED.
So great. Okay, thank you very much. And we've had it sounds like we've got a really cool team that's been helping us. Your lobbyists have been fantastic, Doug, right? So I got to meet them the other day. So thank you so much. Holland and what's it? Holland and what's the other? I can't remember the name.
Holland and Knight.
Yeah,
And
thank you
they
very much.
also have a fresh person to them now is Larry Bouchon, who's a retired cardiac surgeon who
Yes.
spent 9 or 10 years in Congress, or eight, I think it was, in Congress, and he's
That's right. He's from Indiana.
He
He
has
was out
been
of
great
Indiana.
because he gets medicine, and
Yeah,
he's
yeah. He's out of
so much
Indiana,
doctor.
actually.
Yeah,
Yeah,
exactly.
yeah. It's a good guy. All right. Well, I'm gonna run by a couple people that I haven't talked to for a while, and then what I want to do, Keegan is Bradley from our latest member from Arlington. Um, excuse me. We're trying to start a Buke program, and a lot of us have been very matured in that area, some for over 10 years. And so I want him to do a survey, but I think he could shape the survey a little bit better if he just has some discussion with us. So I'm going to leave that a little bit towards the end. Is that okay for you, Keegan, if we do that in about 15 minutes? I want to do some other round robins here. Are you okay with that?
Yeah, absolutely.
Okay, good. And a lot of the people who have great programs aren't on today, which is because they got like David Miramontes, the STRAC program, but there's others that have some very good programs going on, or they're just starting them. They've learned, and I call it an R&D session, the rip off and duplicate, right? And this is going to be you'll have a lot to rip off here. You'll see there's a lot of good programs out there for you. But before we do that, I just want to do a couple of reports. One of the things that's come up with regard, and I've had discussion with Randy Schaefer, who couldn't make it today, by the way, because she's at a really cool session that they're honoring women in the military. I think up in Arlington, Virginia, if I remember correctly, at the National Cemetery. and she was invited to go to that, and I'm going to have a report on it sometime. But we've got Eric Bank, who started the first program, and of course John Kramer and John Jenkins here, and the others that have been so helpful in getting blood programs going. One of the things I heard in various things over the week were that we're having problems with our legal department. And I said, well, that was your first mistake going to the legal department. But, a lot of people have to go do that when they're signing any programs. And so eventually I want to argue it's the whole thing about if you don't put AEDs out there, even if they're not used that much, you'll probably have some kind of, blowback. I want to use the same thing with blood. I hope we're getting to that point pretty soon. But any event, let's move on though, and go ahead and give a quick update if you don't mind. Let's have Eric lead that if you don't mind. Eric Bank, and then have the others comment.
So, we're talking about the blood bank contracts?
Oh, we're talking about anything. I want to know what's the latest on blood. Okay, you and I will be talking about blood banks later this afternoon. I am going to get on with them with you at 1 o'clock our time. Okay.
Okay. So, I mean, I think the biggest thing right now is there's, some pending legislation trying to get the reimbursement part done, which I think is a big part for everybody. This, there was we had a pretty well attended pre-conference, but there wasn't a lot within the conference. But again, like most of the NEMSPs, most of that talk took place in the hallways and at the vendor show. I think that obviously Randy works with blood banks a lot more than I do, but on the government side, the biggest issue you run into is two of the things that are absolutely in there have to do with identification, which no government agency is going to sign. So that always becomes a problem. And then for us in Texas right now, the part of the project that Dr. Jenkins and I are part of is this $10 million fund to push throughout Texas. Is our RACs are going to be responsible for that, but our RACs are not clinical entities, so the blood banks will not do a contract with them. So like if you look at our RAC is Harris and the 8 counties around us is a lot of entities. So now all of those entities are going to have to go to the blood bank and do an individual contract instead of doing one contract with the RAC.
Okay. And then how are we doing? Are we up to 330 agencies out there using it on the ground?
Yeah, we're between 330 and 340 as Randy catches up. And I mean, she's well dug in right now with the 125th celebration of nurses with the Army program. But and as the Texas program comes online, and then hopefully if Florida is successful with that 15 million, that's going to be a whole lot more programs too. And then rumors that North Carolina is going to start the same process.
Great.
So
okay,
we have about a 40 to 45% yearly rate of increased agencies, and I think that's going to be bigger this year.
Eric, I got a hand up from Keegan. Keegan, you have a question for Eric or a question for us?
Yeah, Eric, I had a question to see if you'd heard. This is more specifically on Texas with that $10 million. Some of my blood programs, I had a question because initially a lot of the assistance was coming out in the form of equipment. Are we able to use some of that money towards blood if we already have equipment at our departments? Do you know?
I think it's all up to individually to the RAC. Unfortunately, and maybe Dr. Jenkins can comment on this as well. We still have not seen a contract from the state of Texas on what is in the approved list, what's not in the approved list, and what is the RAC requirements and that type of stuff. I think it's up to the individual RACs, but I don't see why blood can be covered in there because it's for blood products, right? But
yeah. I wonder do you think pushing that at GTAC might help our cause?
So we have pushed it, but I don't think it could hurt. And then kind of the new push from the coalition, and this goes along with Dr. Kupas's advocacy pushes. I think right now, what I think the best process is if we could get more states online like Texas and Florida to pay for the startup.
Yeah.
And then have CMS and commercial insurance sustain the programs. Dr. Holcomb is the one who did most of the work on this. And with a healthcare economist, we're looking at about 25 cents per human in the United States to roll this out to all the EMS agencies in the country. So around $85 to $86 million total, but then that's not for sustainment, right? So.
Yeah. And if I remember correctly, from the meeting we had in Florida last week with the Florida chapter, Charlie was there and Des, I can't remember if you were there or not, But I think it's going to be more liberal in Florida where you could use it for whatever you need it for. Okay. But just get the program started, whether it's equipment or not, or the blood or whatever. I may be wrong. But do you remember Charlie Sand, what he said about that?
Yeah, I'm not sure specifically, Paul, if this is going to answer that, but obviously the focus is on infrastructure. Had
Yeah.
to using that 14.8 million to pay for supplies, the coolers, FTs, all that kind of stuff, not the blood. I don't know if that answers your question. Sorry.
I think so. That's
Okay.
what I'm leading you because I
Okay.
think that's a little bit what I heard here, but we'll
Okay.
just have to see. But
Mhm.
yeah, we'll follow through on this a little bit more. Don, go ahead and I was coming to you anyway, so perfect timing. Don
Hey,
Jenkins.
Paul, can you hear me?
Yes, I can even see your
Yeah.
ear.
So, yeah, I'm in a public place, and so I'm just trying to keep it quiet here.
Sure.
Question about the appropriation in Florida. Is that gone through? Is that in legislation currently?
Oh, it's in the governor's budget, and that usually is pretty good. And then you just got to get everybody to approve it. So that's going through that process right now. Charlie, can you give us a 30-second deal on that? What you know about it?
Yeah,
Because you're
no, you summarized the 30-second deal. It's certainly not up for vote yet. We're getting there. I'm going up to Tallahassee end of February and early March to make sure our ducks are lined up to, for lack of better words. But yeah, we're just waiting. We're following the process where it is and when it's going to be up for the votes. That's when we need to jump in. But I'm starting to rally the troops to call their local constituents. I don't know if that answers what you wanted,
I
Paul.
think so, but we'll give you
Okay.
more of a follow-up later, Don.
Yeah.
So it's going to take a little bit
Yeah.
of
So
while.
I guess my question would be, what's the expectation if it were to go through? When is that kind of thing usually come around in the summer or?
Yeah, July 1st.
Gotcha. Okay.
Oh yeah, and I'll tell you, Ken is so confident about it. He already started telling people to put their protocols together, get ready to order equipment, and get that stuff in line so it could go into effect July 1st. Because what they do is then they do evaluate. There's kind of a process of where they evaluate, did this thing work? So if you're just getting started in July and then not catching up till December, they won't have enough numbers to say this works well. So it's just kind of an interesting thing. So I'll have Ken on maybe next week. I'm hoping to have him on for that other thing we were doing about medical directors, and have him give you a direct report about that. So that'll be good. I'm sorry he couldn't get on today for various reasons. All right. All right, let's move on from blood unless there's anything else to add. Don, are you doing okay? And they want to say some nice words about, you might as well, about Craig Manifold, right? Because most people don't know. They just think of him as the doctor or the doctor who was the medical director, the editor of the textbook for for NAMT, etc. But he was an Air Force person, right? Right, Dan, Don. I don't know if you heard me. Don's in that public place. Maybe he's not hearing me.
Yeah, for an entire career, and then when he left active duty, he became the Texas State Air National Guard Surgeon General.
Yes, and it's unbelievable. He's just an amazing human being, and so we are so privileged to have him. So sad to lose him too. And right, what was that? October 20, right? Wasn't it? I think I remember. And
That sounds right.
yeah, so awful. All right, so let's move on to various reports from various people. Oh, John Kramer, I'm sorry I left you out. Anything else you could want to report on from the blood end, or anything else you want to talk about? It's
Yeah,
fine.
no, I think Eric covered it well. As the discussion has identified, it's important for the states to get together as well. The programs in the states that are either operating or starting to build their programs, because how the states are going to address it is going to be unique to each state. So,
Yes,
yeah,
good point. Yeah, that's it.
works in Texas will not work in Michigan.
Yeah. The only thing I hope we can at least get better at is how we collect the data, the registry information, all the stuff we talked about a couple of weeks ago. But
Oh,
let's
yeah, that,
we'll readdress that later and come
that's
back.
all in the works. Yep.
Yep. Okay, good. All right. So then let's just start. I'm going to do a couple of round robins with different categories or people I haven't talked to for a while. If you don't mind, just to sort of get back there first. So, for example, one person that we hadn't heard from for a while, was I'm trying to see who it was. Let's see if there's. Oh, Russell, anything in El Paso we need to know about? And then Sean, I'm coming to you next about Honolulu.
No, nothing too new here other than my contract with Blue Origin. Interestingly enough, they've paused all suborbital space sort of vacationers
Yeah.
in an effort to solely focus on getting back to the moon. Apparently, the administration is putting a lot of pressure on SpaceX and Blue Origin to accomplish this. So they
Yeah.
pulled all the engineers off of space vacations, and now they're working on their big project. So
Yeah.
that's really the only update that I have for you guys.
Okay, good. Then it's great to see you. Hey, Tom, as Ladara is one of our new people coming out of Connecticut. Can you tell us a little bit anything new to report out of Connecticut or what you're working on?
Hey, good afternoon, everybody, and thanks Doug and Tony and Paul for putting together a great talk today. Appreciate you all. We just recently purchased an ambulance company. It does about 50,000 ground transports per year. So spinning that up and kind of integrating it into a health system and going through the joys of merging an EMS operation with a health system operation, as I'm sure some people can sympathize with, and then kind of respinning up a ECMO transport program in this area with some new cardiac surgery leadership, which again, kind of a multidisciplinary partnership, but welcome any expertise or guidance any folks who have been doing that for years have on those topics, and thank you all for the great work you do across the country. Appreciate you.
Well, if you want, especially with you talk about your ECMO program, there's a couple of us that have done that. And so it'd be great if you want to come back and just give us a 5-minute spiel about what you're doing. Then we can see what other people have to say to react to it. That's what I'm planning to do here with Keegan today, for example. Okay.
I would love that.
So,
Thank you.
yeah, it's good. Thanks a lot. How's the baby doing? Okay.
She's great. She's got about 10 more minutes in the nap, and we're waiting for the aftermath. So we'll see. We'll see. I'll see how that goes.
Well, it's great to see you. So you guys got to get me up there again. It'll be kind of fun and hang out just with you. So
Come on. You're always welcome.
Okay, good. All right. Let's move on to let's see, who did I want to talk to? Well, first of all, Ben, because you hadn't been able to get on for the last couple of weeks, Ben Weston up in Milwaukee. And so anything to report out of there, either on the public health side or on the EMS side? Hope I didn't catch you off guard, Ben Weston. If not, and Eileen, just so you're warning, I'm going to be going to Jim Augustine to talk about the measles outbreak down in Florida, and then have you comment on it. Okay, so
Sure. Okay.
hey, Ben, are you there? Maybe not. Maybe he had got as busy as he is. I'm sure that's what happened there. All right. So before I head over, I didn't see. I was looking for Mick to see if he was on from Dublin, but Vicente, anything out of Iceland or out of Spain? I don't know if I caught you off guard. Vicente, can you hear me okay? Maybe not. Okay. So you get the rest of you are hearing me, right? So Vicente, can you come on? Are you hearing me? So we'll come back to him later. Okay, got it. I wanted to make sure we caught him before he had to leave. So it's getting late there. All right. So then let's see. Hey, Stein, I just want to ask you, you had a great trip to New Zealand, and can you come back maybe next week and talk to us about the adventures in Down Under in the territory of All Blacks?
Oh yeah, it was it was quite an adventure.
Yeah.
I left Colorado where we were having a sort of a multi-decade unusually hot winter to a multi-decade unusually cold, snowy New Zealand summer. But it was awesome. Sure, be happy to.
Yeah, give us a kind of a nice little, a tourist, let's say, tourism guide, and just and your interactions with the folks down there. That's good. But anything else out of Colorado Springs we should know about?
No, nothing major.
Okay, good. And then let's you and I get together and update the website so we can start pushing the meeting in, it's pushing to the meeting in a couple months, whatever it is, June, right? So we'll do that.
Yep, absolutely. Okay.
All right. Well, let's then go to let's see. Let's go to Jim. Let's go ahead and do that. Let's get onto the infectious disease realm. Okay. So go ahead, Jim. You've had an outbreak there. Is that right, of measles?
Yes. Actually, a week ago, EMS in Collier County got a call for a student who was ill at a small college campus in the internal part of the county. When they get there, they realize there's not one, there's multiple students who are ill with measles. And it was being managed on the campus. And from that point, kind of, we came to realize we have a campus where there's a lot of students who are not immunized against measles. The campus is wide open. Activities are wide open. The students are in rooms, very small rooms with 4 students, with the ill in the middle of the unvaccinated, and all kind of activities going on. There's no controls whatsoever. And a week later here, we're at officially 100 victims with no controls of any kind.
Yeah.
Department of Health in this state is under a certain set of guidances that do not relate to Ken Shepke, and we will we're just going to watch this explode. This will be no doubt the largest measles outbreak in the country.
So an interesting comment, though. We always think about the elderly being less more immunocompromised, right? Because they're losing their immunity abilities as they get older. But the irony is that probably in this case, most of the elderly got measles when they were kids because they didn't have vaccines yet, and so they're relatively protected, I would get, from the natural disease, which is really contagious, but on the other hand, doesn't rotate that much. It doesn't evolve too much. Maybe it is evolving, and maybe Eileen can tell us. But for the most part, that it's kind of an interesting twist on things. Whereas we usually have the elderly people going down for the flu because there's a new variety that's out there. So Eileen, you want to comment on this?
Couple of comments. First of all, genotypically, there's a bunch of different types of measles. However, serologically, there's only one type. And that's why when you get the measles, you pretty much have lifelong immunity. However, and so your comments are very apropos. However, some people, as they get older, first of all, we all lose some immunity as we get older, unfortunately, but also some people very specifically have lost immunity to some degree to the measles, and they get an atypical form of measles sometimes in the elderly people where for example, the rash, which normally starts on the face and goes down, can start on the back or the chest and spread in other directions. So it's wise, especially for anyone in the county of it is Ave Maria. We don't have to be secret about it. It's all over the news. And by the by, my nephew attended Ave Maria for his law degree, and he can attest to the fact that it's a very, very conservative university where it is a known fact that they have a lower vaccine uptake rate, well below the 95% that you need to prevent a measles outbreak. And so it's no surprise that of all the universities in Florida, this would be a key place where an outbreak like this could happen. And from my understanding, it has spread north and south from Ave Maria because of travel by students. You seem to have a question.
A quick question about Ave Maria, and that particular university. And I don't want to bring up anything that seems to be, politically incorrect, but is there religious or political or philosophical, bent towards the students that go there, or
yeah, it is a Catholic university.
Okay. And so I've not known that the Catholics were particularly not interested in, getting vaccinated. Was there an issue there, or is it just a generational thing nowadays?
It's been over 20 years now, actually over 25 years now, since the false publication of the false data about autism and measles that led a number of people to not vaccinate their children. And so, and as that, people have a real hard time who don't do science, who don't do what we do, distinguishing false from real information that is scientific, right? So they have a hard time. So they can't tell. I can't tell you how many times, patients, people, et cetera, come up to me and, oh, is this crazy thing true or not. I heard this talking head. They can't seem to distinguish somebody like Paul Pepe and all his credentials saying something and the dog catcher saying it, which I really wish they would. Right. And that's a real failing in our society. So that is a big part of the problem. I see Terry's asking about getting revaccinated. Since he and I and you are of an age, the answer to that would be just go ahead and have your titers checked. If you have high titers, don't worry about it, right?
Right.
But one really important point on this issue, which drove me crazy. I mean, crazy. This an ID doctor had the gall to ask a group of infectious disease expert, of which I'm one, right? Whether or not he could just not wear his mask around measles patients since he'd been vaccinated twice and he had really high titers. So why should he wear a mask? And I'm thinking, you bozo, you big bozo, it's not about you, it's about the patient and the fact that the measles virus damages memory B cells and memory T cells, and whatever MRSA, whatever junk he's carrying around that might not be measles can kill his patient. I mean, you got to think of the patient. You know, it's not so, the selfishness drives me nuts.
Yeah, exactly.
Lack of community.
Well, better, because I think it's that thing was a lot of damage. Then, of course, you have, you know, a HHS secretary who had that bent and become somewhat political as well. And then I think that got amplified during COVID a little bit, which is just crazy. So that's it. Hey, Mike Feldman asked a question, Jim. Maybe you know the answer is the International Association of Fire Chiefs medical director. Are people well vaccinated, or do we know that there are people who aren't vaccinated against measles, and what do we do about them, right? And especially pregnant women and all that, right? So,
typically, to get into fire school or in the EMS program here, you have to have proof of vaccination. And so we would have a tendency in this state to have higher vaccination rates amongst the fire and EMS population.
Yep. Okay. Does that answer your question then, Mike? How about up where you are in Toronto?
I think they have to supply when they're hired the proof of titer or vaccination.
Okay.
They have to sign all those off on new hires, and so I think we're okay.
Yeah. Okay. Got it. At least for now, right?
At least for now.
Paul, can I let you know? So we have a situation. DOH is not able to respond. So it was my job as EMS medical director to be convening the group that needed to discuss this quickly. So around our office, we brought together what was needed, which were instructions for patients, instructions for exposures, some idea of what the hospitals and the clinics were dealing with. Our Ave Maria University is unfortunately right next to a city which is full of all of our workers, many of whom are hiding and don't want to be out and don't trust any authority. So we very quickly had to move into programs to protect those farm workers and others. And it was necessary for EMS essentially to just stand up as the lead force with the blessings of our local Department of Health and our county departments of health. So just want to make everybody aware of how you can be thrust into the front of this very, very quickly.
Hey, interesting sidebar. I'm sorry, it's a little off topic, but it's probably is that there was this huge freeze. I mean, we were down 30, 31, 32, 33 in Miami, Fort Lauderdale. Unbelievable, right? But even Central Florida had snow flurries, etc. We knew it in the Panhandle before, but now it's moved down there. What happened to the crop? Did it injured crop? Do we know yet?
Yeah, we've had multiple days. It's done unbelievable damage to all of the crops down here.
Yeah, so that'll have some, for those of you who want to have a glass of orange juice next year, you know, it'll be up there, just like the movie Trading Places, right? All right. So, Libby, what were you saying about Hawaii Hospital? Go ahead, Libby, what were you saying?
Yeah, it's helpful in Hawaii because all the students need to get vaccination before the hospitals will let them do their rotations. So that's worked well in our favor because we know all our guys are vaccinated or they can't get through the programs. Yeah. But we're having an outbreak of chickenpox here on Kauai.
Oh,
I think they've got
on where? Which
on
one?
Kauai.
Kauai, really?
Yeah.
Interesting.
We started with 4 cases, and I think it's spread a little bit through a couple of schools now, but
Any
unvaccinated
explanation?
kids.
Oh, got it. There's the explanation there. Okay,
Yeah.
got it. That's too bad. Do you see Kauai often as a little bit more of a outlier populations that are out there? You know how there's different populations in different places, just like our Makawa Cowboys, right?
Yeah, no, definitely there are certain geographic locations scattered on each island where you would expect that you might see higher rates of non-vaccinated people. Yes.
So that's what makes it really tough that it affects everybody else. So, all right, well, thanks. So then let's see. I'll start moving around the room. Any other discussion on communicable disease that want to bring up? Speaking of communicable disease, I just wanted to catch up and see what happened in New York City because the strike was a communicable disease up there, right? The nurses' strike. What's happened now? Is that resolved yet or still going on? And how's the effects on you right now, Glenn?
Yes, unfortunately, it is still going on. This is coming to the end of the 4th week, the longest nursing strike that we've had. This is day 26. So, as we mentioned before, 3 hospital networks affecting 10 hospitals, and negotiations do not seem to be going well. We got word from the hospital end that they actually have budgeted for travel agency nurses to be hired until February 23rd. So it looks like it's going to potentially go up to another 2 weeks.
All right, got it. Yeah.
So, we're keeping track of it from the EMS end, the state's involved as well. We're giving our diversion lists hourly to the state to let them know what kind of diversions the hospitals are requesting.
Okay.
So they can kind of keep track and they could put pressure on the hospitals as well as, unfortunately, 50% of the system doesn't offer diversions, but we still do as a courtesy.
Yeah.
Our volume, the first 2 weeks of the strike were really much lower than normal. But since the ice storms and such during the actual snowstorm, volumes were lower, but the day after slip and falls and car accidents went right back up to 4,800.
Okay.
So we're still sitting at that higher level. So it's unfortunately still 15,000 nurses out of the 10 hospitals, as I said.
Got it.
And we're trying to monitor it. We have daily state meetings
Yeah.
and also New York City Emergency Management.
All right. Well, listen, before I lose a lot of the group, I want Keegan to start getting some feedback from us. Before I go there, though, Keegan, because out of curiosity, I got to go to you. I had one other thing I wanted to bring up, which is going out to Stanford, San Jose. Mark, are you going to be involved with the Super Bowl or your people from your team who have Santa Clara?
Yeah, a lot of the activities surrounding are taking place downtown. A lot of street closures downtown San Jose. We have some foot teams out and about. So far, everything's been going pretty well, though.
Okay, got it. And then any particular things that like for example, I was wondering what your current plans are, et cetera. And the reason why I was asking that is that I remember what Meg stayed out in the periphery, not in the stadium, because that was covered really well, right? And how about you guys? How are you handling that?
Yeah, no, I'm going to be actually watching the game at a friend's house tomorrow.
Okay, good for you. That'd be really cool if you could watch it tomorrow because
Oh,
it's
oh
not
yeah, okay,
playing
sorry.
on Sunday. You can tell us
Well,
tell us who
exactly.
won
That's
so we
how.
can bet appropriately.
That's
Okay.
the key to good betting is know the outcome a day ahead of time.
Yeah, exactly right. So that's good. All right. Well, I just wanted to see if there was anything special that was going on, especially as we were it's coming up. It'll be interesting. All right. So let's go ahead to Keegan. Keegan, tell us what your plans are, what you'd like to know, and I'm doing this because maybe we should design a survey from you. But what you hear today may help you design that survey better, as we have found. So let me just open it up. Tell them what. Bottom line, we want to see what people have some BUPE programs going on around the country. Some of them, as I said, were very matured, going on for a long time. Keegan is just getting ready to, I think, to start one. Maybe I'm wrong, but he did want to know what were the models out there. And so if each person who has a good model can raise a hand and tell them. But Keegan, go ahead and tell us what you're just start us off as the lead off batter here.
Thanks, Paul. Yeah, I just wanted to engage with everyone here. That was something. I'm aware these programs have been out there. And I heard quite a bit about it. It was a pretty hot topic at the conference this time around. One of the things that's kind of instigating with me is out here in Arlington, we've kind of been having some spikes of Narcan usage and opiate overdoses. And we're, interesting that we work with PD typically when we start seeing these spikes, tell them where we're getting these calls from and everything. But I think that was something we'll probably be wanting to push out into the city. Some of the people I've talked to are usually on smaller cities or counties, so it's a little harder to reproduce when you want to approach a bigger city like Arlington and say, hey, let's do it here. So I figured, this is probably the perfect group to, like Paul likes to say, just kind of copy and paste if I can from someone who's already figured it out and is doing it right, as opposed to trying to go reinvent the wheel.
So we've heard a couple of really good programs up there, and some of the people who I would like to have you on with, like Ken Shepke or David Miramontes, that's some good programs aren't on with us today. But we have a couple others that are on today that have pretty good programs started up already. Anybody want to volunteer or raise a hand and engage right away? Stein, go ahead.
Well, I'll do a really quick one and then leave it to probably larger programs. But our program was designed after San Antonio, and it wasn't an exactly cut and paste, but it pretty much was. I'd be happy to talk to you about it. I think it's a really good idea to try to get a global idea of the status quo of some of these programs. We started ours last year. It was pretty successful out of the gates, and it's designed with a social worker and a paramedic that go around and attach themselves or follow up for MAT initiation. Interestingly enough, and I wanted to bring this to the Eagles, and maybe we can just kind of add this on at another time, is that we've found that there's been a precipitous drop in the need for us to be going out and giving BUP. And I think that it may be because there's a lot of opioid money out there and a lot of pop-up clinics and a lot of other places to just turn around and get the Suboxone. And so we're trying to go back to the dashboard, actually, to the drawing board and try to figure out, where do we fit in? How can we do this? How can we still be useful? I'd be interested to know if there's other places that are experiencing that.
All right, so let me start by, first of all, let's say you go and encounter a overdose, you give them some Narcan and, right? And then what happens? Do they now communicate that to somebody, or is there a clearinghouse? And then in other words, we've identified a person who you should be treating. How's that work? Or does it start at the hospital, or where does it start there?
Yeah, so for us, it can start from many, many different places. But if it starts from an EMS initiation, a lot of times or sometimes we will attach ourselves to calls that were given Narcan. We try to get to them as real time as possible. What we've recognized is that if you have delay in getting to contact with these people, literally every hour, and especially every day that you have delay in getting to them, it's harder and harder to make contact. So we try to make contact as soon as possible, sometimes even giving Suboxone after Narcan administration. Although depending on how heavy the use is on those people, we have to be careful about doing that as like a hot initiation right after Narcan. And so we do it through EMS calls. We do it through community and public health referrals. We do it through hospital referrals. A lot of the hospitals will get patients in the emergency department, and then they will actually contact our team to come help follow up on these people. And our team really gives only a few doses up to several days, but it's not meant to be their treatment program. It's meant to, we bridge them to a place that they can then get Suboxone or buprenorphine in whatever form on a regular basis.
Before I go to Rob Lowe, Libby's asking a question: how readily can you hand off patients for treatment clinic, etc.? That's our issue in Hawaii. You want to comment on that, Libby, or just expound on that a little bit?
Yeah, we have legislation this year, and we've been looking at it for a while. I looked at Miramontes's protocols and stuff for paramedics to administer BUP in the field. But our issue is that there's no place to hand the patients off to. We have precious few treatment centers or facilities, and I don't want the paramedics to get stuck, essentially becoming the primary care provider for these guys for weeks at a time.
That's actually a good point. You remind me about the thing Shepke did because he'd been doing this in Palm Beach County years ago when they had the pill mills, and he got right when they came in the emergency department, they identified they got plugged into a system, had people visit them, then they got them in the clinic. So that was all kind of a system. He more recently started what they call the CORE program, which is actually they had kind of centers for bringing overdoses or people with opioid problems too. So it was automatic. It's like taken them to a trauma center, and then there's rehab. It was a very organized systematic approach. That might be a good person for you to talk to, Keegan, as well. Rob, tell us a little bit about what your experience has been in Columbus, for example. You guys have been doing it for a while as well.
Been doing it for a little while, probably not as long as some others. So we use a similar model. It's a secondary response team. It's a medic and actually a dress down.
How are they? I'm sorry, I interrupted you. So you said social worker as well?
Occasionally a social worker, but often that REACT team, that secondary harm team, is just the paramedic and the dress down police officer.
Oh, okay. And then let me ask you this: how are they contacted? How do they know about the patient?
So the crews can make direct referrals when they're in service. They're also kind of surfing the charts, if you will, the day after and looking at these folks. Their job already is to follow up on all these overdoses. So giving them this capability made a lot of sense. One of the things we did to try to convince our crews that it was worth calling them and waiting on scene is we allowed our crews to hand off the run report as well. So they don't have to write a run report on these patients. They hand off to the team. The team will take care of it for them. We noticed the same thing. So when we launched, we thought we had this many cases that we were going to be doing, and then our overdoses kind of dried up. In fact, one of my busiest stations, the captain came to me about a month later and said, "Doc, I don't know what you're doing, but we've had 2 shifts in a row with no overdoses." And it was just odd timing, I think, or what was happening there.
Okay.
The thing about the clinic, we're just very fortunate that we have a clinic here that's willing to take folks, no questions asked. They're open about 6 days a week. And so we do allow that team to redose for 1 day. So because they do this follow-up and because they do a lot of working with folks to get into treatment, they have that option of redosing if it's, there's some other thing that has to happen in life to take care of things right now. We'll get you your treatment. We'll set up the clinic for tomorrow. But most of our cases, they're willing to go right then. So
before I go to Jim Augustine, Joe Zalkin, can you tell us why did you put in the contact in Wake County? What's that about?
Wake's got a pretty mature program, similar size to Arlington. And
Yes.
luckily, the community does have resources for referral. And their kickoff was bringing BUP into the jail so that incarcerated folks didn't miss that. Jose worked a lot to get that in place, but the mobile system is very similar.
Okay, got it. And then, Keegan, can you get that email address there for Dr. Godfrey?
Yeah, I just copied it actually, and I'm glad you mentioned that because I was talking with one of my operations directors. He said, let's start in the jail. So that's actually perfect.
Okay,
timing
good.
with that. So.
Hey, Jim Augustine, you guys, maybe you could comment a little bit on the CORE program in Florida because you've taken advantage of that and actually helped you with other projects after that, right? So, yeah, can you give us a lowdown on what you did in Lee County?
Yes. Again, thanks to Ken Shepke, we went and looked at Palm Beach County, decided that we should be a gap filler and that our primary role in EMS is gap filling. And Keegan, I would urge you to do that. Talk to your existing methadone clinics, the addiction centers, and addiction medicine at the hospital. There's gaps to fill between the program, and that can be your primary. And our advantage is always we're a 365 program, and the others are not. And so we started by filling gaps, but didn't want to be replacement, as Libby is saying, for the primary providers, methadone, the paid hospitals, the centers of excellence that Ken Shepke keeps talking about.
Yeah, tell us, I don't know if I want to put you on the spot, but can you tell us a little bit about the CORE program, what you know of it?
Yeah, Comprehensive Opiate Recovery Network, CORE program in Florida, a well-funded program from the opiate dollars. And that was to design centers of excellence and promote any form of care that could reduce the addiction population in the state.
So we
And
could take people there, or we could refer people to those hospitals, et cetera, those centers, correct? So
exactly. Yes,
yeah,
sir.
okay. Go ahead. Then,
No,
but that
just-
go ahead, Jim.
Just you shouldn't replace the existing resources, and you should find every way to work with them.
All right, got it. So one thing I was going to ask you though, that helped you with other spin-offs as well when you started doing that, correct? Tell us a little bit about that.
Yeah, so we used our initial opiate dollars and core dollars to build our community medicine program. And since then, the hospitals and other agencies have contracted with us that extends our community health program out. And we found a lot of other extensions. As soon as you get into the opiate population, right next to it is the alcohol program. So then we're into alcohol dollars as well.
And that also has an effect on homeless or unhoused people, whatever. Is that right?
Yes.
Because
We have
so
a lot
much of
of-
that is related to those things, right? So
Right. And we have people who are accustomed to working with them. And then you have your whole EMS force who's feeding you referrals and giving you correct information. We have all the same exchanges. At times when our people go out, they've got somebody who's having an acute medical issue. There's no problem getting them involved. Our addiction medicine at the hospital is very supportive because we extend the program and reduce their readmissions.
Okay,
All important steps, Keegan, to make the program a long-term success.
before I ask other people to make some commentary, Glenn, I saw you put something in there, and you and Mike were talking about medically assisted suicide. Does that involve EMS? Because what I'm gonna do is maybe have you come back and talk about that. Why did you bring that up here?
Yeah, we're getting word that the governor's about to sign this legislation that's going to allow it. And I know there's a dozen or so states that do allow that. I was just wondering, we're trying to figure out, will we get EMS calls for that? And Michael told me up at in his area that occasionally his paramedics would get called there to start the IV, and he didn't mention that. It's interesting. I can't imagine there'd be botched attempts or change at heart where maybe they started a procedure and now they have to call 911. But I was just wondering if anyone had any experience with that, just so that I can kind of start to kind of get an idea of what we might expect. I think it'll be very few, but.
All right, so maybe you and Mike can come on and do a presentation about that down the line. That would be kind of interesting, I guess, and maybe even talk about that in Fort Lauderdale, because if it's happening, we need to be prepared. And then also to go back in the policy, I just forgot. I wanted to say, Jim, I don't know if that's something you could get out there, but your policies or what you've developed, or if you're still in progress about the measles. That was one thing I wanted to make a comment to you. Who just had their hand up that just put their hand down? Who was that? Was that
Hey, Paul, it's Shay.
Yeah, Shay, go ahead.
I was just going to say we had a case early on in Colorado that Denver paramedics ran where somebody that was on scene with the medically assisted suicide actually tasted the concoction and was, as you might imagine, quite ill. I think they made a case report that was published about that, but anecdotally, we don't see a ton.
Okay.
Thank you.
Yeah. But is it going to increase is another thing. But if you want, I don't know if it's worthwhile, we could bring it up for future. Maybe since you have a program where you guys are setting up the IV, Mike, then maybe tell us about that. Okay. So
Yeah, I'd be happy to talk about it.
okay, got it. Remind me later and I'll set it up. All right. So let's kind of blast around the room if we can. Vicente, are you there by any chance? Just wanted to.
I'm
we only-
here.
Yeah.
I'm here.
I was trying to reach you before. So anyways, anything out of either Iceland or Spain or whatever,
No.
or any other? Okay. All right.
Nothing new, nothing different. Just the aftermath of the train crash.
Yes.
Still, I think there's only one patient in the ICU. Total toll was 50 something. But there was a problem with the tracks. There was a problem with the tracks.
Yeah, right.
Nothing else. Thank you.
All right, good. No, thanks for being on. We love having you. Okay, then let's jump up to anything in Philadelphia to report. Crawford.
Hi, everyone. Just still dealing with our cold weather response in the city, getting our new medical directors get settled in, and glad that we're coming close to meeting the New York criteria for number of medical directors per paramedic. And also we had, you may have heard, sort of a sad incident yesterday involving Philadelphia and Camden, where a Camden firefighter from the Marine unit fell into the Delaware River, which was frozen at the time, got trapped under the ice.
Wow.
Both
That's
Marine
insane.
units, the city's Marine units responded, and unfortunately, after 35 minutes under the ice, he was pulled out and he died. So kind of a sad day.
It is a sad day. Hey, can you be on next week? Because that's where we're going to have the discussion about multiple medical directors. They're trying to do that, of course, in Los Angeles. And then, of course, there's why should we pay for more than one medical director is going to be the topic, right?
Of course.
We just need someone to sign the protocols, right? So, especially in large cities. So that'd be great if you could be on next week for that. That's terrific to add on to our whatever, our grouping there. Okay, so then are you still on Baltimore? Are you guys there still? I can't remember if you got off. You might have gotten off. Are you there, Ben? Didn't know if Ben got off. Okay, then let's pop over. If not, if Ben's not there, let's pop over to Chicago. Anything to report out of there, Dick?
Good afternoon, everyone. A couple updates. We've had 10 cases of meningitis linked to the shelter network in Chicago. So the Chicago Department of Public Health, the fire department are currently working through that in conjunction with the hospitals. Haven't been on the past couple of months because we've had our technical rescue medic program modeled after FIDNey's rescue medic program. It's a first expanded scope program in the city of Chicago. Paul, you got to see a little bit of that when you came and visited. Had a great time. We're expanding the use of AutoPulse for high rises within our community, and we are working on contracting now for a pre-hospital blood transfusion program. And so we're working hard to try to address some gaps and moving forward. So thank you very much.
You obviously are keeping pretty busy, that kind of thing. And and I don't know how you have time to go over to places like Volare, but you do. You're just a busy guy. I'll say that. So with that, Nick, I just wanted to ask you, you guys have at least 5 medical directors there, right? In Chicago. That might be part of the conversation that we have next week. I just wanted to make sure. But do you have additional assistant medical directors? Do you have assistant medical directors working with you directly with Chicago Fire?
So we have hospital-based EMS, and we have 4 resource hospitals, and many, Dr. Weber, Markle, Perlman, and Katie Tateris, you guys know them. Great people, collaborative nature. But in terms of the fire department as an agency, I serve as the medical consultant for them. And so we work in a collaborative fashion, though.
Okay, got it. Just the whole issue of, we really want to support that it takes multiple people to do a multiple job, right? So, all right, let's see now. Who have I called on for what? Well, while we got you on, Rob, anything out of Columbus we should know about?
Nothing much more, Paul. We did leverage some information from the Eagles about 2 years ago, and so my medical direction team's up to about 1.5 now.
Okay, got it.
I could use more, but at least helped a little bit.
You got it. Okay, Shay, anything from Denver? Who is that? Okay.
Hey, Paul, not much. We're in the process of interviewing for our permanent paramedics medical directors. That process is ongoing. Otherwise, we're continuing work on our kind of dispatch determinant-based response program. Hoping to get a pilot program by the end of the year or middle of the year. So excited to kind of report back on that.
Okay, good. All right, fantastic. And all right, so then I got to work on getting at least your interim medical director on with us, and hopefully part of it. When do they think they're going to make a final choice about who's going to run the DHHA program?
It's moving pretty quick. I would bet within about a month we should have somebody named.
All right, just want to make sure they know that a really important part of that is to get down to Fort Lauderdale with us. And
Absolutely,
that's
absolutely.
great.
I'll be there. I'm hoping we can get that person there.
Okay, good. Well, at least hopefully we'll have you. I just always have to the diversity, having people with different experience. You guys had some very interesting experiences over the last couple of years there. Hey, Desmond, anything to report out of your area? Fitzpatrick?
Yeah, pretty interesting, of course, with the cold. The fountains at Epcot froze. So
get out of here.
Beautiful pictures there. Something that I'd love this greater group to talk about is, as we're pretty progressive with ECPR programs, things like that. NMSB had a great lecture talking about the old debate of stay and play versus load and go. And that's kind of where we're at now. We're trying to find that fine point between when we move an eCPR candidate versus staying and just doing, again, high quality CPR, AP, and dual sequential. So love some information on that at a later date.
Yeah. So, and you guys have done a great job, especially working with Carrie and others on starting resuscitation centers, and that's part of it here as well. So that'd be great. If you want, it would be great to have you do a quick, you don't mind, do a quick presentation on it for one of these Fridays, then, and then also down in Fort Lauderdale for the.
Sounds great.
Yeah, I love it. The thing is, I was sitting, I had just heard a talk again about double sequential, and unfortunately, I feel like when I came up with that thing, and based on some visits I had done back in the 90s with electrophysiologists, I think it's a little bit of a misnomer, because I think the real issue is the vector change. And Joe Arnado, really pointed that out to us. I guess Stein will tell you, back in the 80s, he knew all that stuff. He was doing great work on that. And it really, I usually, just I've switched my terminology to multi-vector, and I think that the AP approach was always the best approach if you're going to use a single pad, but that kind of thing. So just a little editorial I was going to make, that's all. So all right, and then let's see, let's move on. Hey, Julian, while we have you on there, I just wanted to say thanks a lot for helping us with this. And if you can download those things that we've missed so far, in terms of is there something else we have to do or work with the website people, or what's happening on that end? Do you know?
I can't speak for the website. I think Dr. Bronski can, because I don't really do anything with that anymore. But the YouTube page is uploaded, the day of or the day after. So if you link people directly to the YouTube playlist, then you won't have any issues.
Okay, good. All right. Stein, did you hear that? I just want to make sure we're doing that, because sometimes people can't get on or couldn't see the more recent ones that we've done. And Julian's done a great job of taking care of that.
Yeah, he certainly has, and that is uploaded very systematically. It's there. Sometimes there's a few hour delay, just for timing of Julian, of you being able to get it up there, but it is really up to date and should remain so.
Okay, and Stein, you want to make a comment about what I said about Ornato doing all this stuff 40 years ago, and that it really is multi-vector, right?
Oh yeah, when I was in residency and fellowship with Ornato, we had the 80 lead EKG vest that we were doing. So that was 80 vectors. And that was very interesting.
I know, it was like and it only took like 5 joules and you convert them, because we used to think that it was a bag of worms, but the thing's moving around in different directions. You're more apt to catch it if you do it in that direction versus the sort of over the side on the heart, that kind of thing. Even if you went deep, it just was it was easier to do it that way. So any event, it's phenomenal how much stuff like I learned from Joe, from Peter Saffer way back, in the day. So it's kind of an interesting thing, and to see it's like some things coming around now. All right. Anybody? Oh, I don't know who I've missed here, but anybody else want to just add? So we've gone over time, but anybody else want to pop in and make a communication about anything before I set you off to the next roundup, Cowboys?
Anybody following the Nancy Guthrie case in Tucson?
What about it?
The blood on her front porch is DNA positive for her.
Yeah, that's what I heard.
And my penultimate wife lives about 6 or 7 blocks from that area, so I've designated her, the sheriff, as a person of interest.
That's great. I was told, by the way, by our police here that I'm a person of disinterest, right? That kind of thing. Hey, but on that, based on the blood where it showed up, where would the blood be on her? Did it come from a head, down below? Where was it? There's
no way to know. There's no body.
Yeah, I know, but I'm saying the blood, was it high up on some furniture, low? Was it where
It was on the front porch.
Front porch, okay. And so you think it dripped down, or is that what they're thinking?
I'm with the sheriff on this. You can speculate all you want, but that's
right. Did you send the ransom note? I just want to know.
Well, that's a sick thing about this. There have been multiple ransom notes sent by.
I know, that's why I'm being
Yeah,
sarcastic. Yeah, it's really awful. All right, well, it's keeping everybody hopping there. So, all right, well, listen, everybody, great. Everybody have a great weekend. Welcome back, my friends. The show never ends next next Friday. Unless anybody else has anything else, I'm going to try to sign us all off. So, all right, thank you for everybody who contributed today. Really appreciate it. Okay, we'll see you later then. Take care. Bye bye.
Thank you. Bye.